morning, everyone. My presentation for the EGVRS school uveitis session is called Don't Trust This Beast, and it's about common yet tricky Behçet cases that you are maybe confronted with. So, we have seen in our uveitis clinic in Aslayani maybe more than 600 documented Behçet patients with variable presentations. So we learned somehow to survive with this disease with its variable and very tricky and malicious presentations. About the Behçet, as we know, it's a multi-system vasculitic disorder with a common triad of oral genital ulcers and uveitis. It affects the eye, causing vasculitis. Treatment is systemic steroids, immunomodulatory treatment, and the recent game changers, which are the systemic biologics. Also, there's a role for local treatment as subtenon injections. Our patients, unfortunately, are young, productive patients with 25% chance of eventually going blind on treatment, even on treatment. The disease affects maybe 20 per 100,000 in population, but we think that this diagnosis is even less. The numbers are even, the estimates are even less than the actual. So we think that in order to conquer this enemy or to live with this enemy, you have to learn all the moves of your enemy, including the very, very uncommon moves. So here we have the three tricky scenarios. They're not very common, but they exist. First is a 22-year-old male with bilateral hypopyon, yet he has no other systemic signs of Behçet. The second is a 26-year-old male with a branch vein occlusion. That's the presentation, and he was directed towards the hematological clinic. Third one is a female with 35-year-old mild anterior uveitis and subtle vasculitis. For the first case, that this tricky case, he's a 22-year-old male presents with hypopyon in one or both eyes. Fundus is unseen from the severe reaction, anterior chamber reaction, and the ultrasound is okay. So the doctor, non-suspecting doctor, asks the patient, do you have oral ulcers, genital ulcers? And the patient denies, he says no. So the doctor considers him either idiopathic or HLA-B27 related acute anterior uveitis, which commonly present with hypopyon also, so he gives him topical treatment, even low dose oral steroids. What happens is that anterior uveitis resolves on the treatment. Still, the patient with this low dose treatment, he has subclinical posterior uveitis that will cause him eventually vascular occlusion or optic atrophy, and the patient may go blind from insufficient treatment. So in this previous scenario, did the doctor miss anything? Yes, he missed something, which is, first is the Behçet is commonly now diagnosed by something called international criteria for Behçet disease that doesn't rely solely on recurrent oral ulcers. It takes into consideration other things like superficial thrombophlebitis, arthritis, so you can gain the points to diagnose the Behçet from other clinical signs. Second is the uveitis can be the presenting symptom in these patients in up to 10%. So your patient, if you ask your patient the same question, he might well turn one day may turn and he will say, yes, and now I have oral and genital ulcers. And the third is that the patient even may misinterpret the concept of oral and genital ulcers. So maybe sometimes he's embarrassed even to answer. Our second case is a 26-year-old male patient presents with only a branch vein occlusion in one eye. So the doctor asks about hematological and vascular risk factors. As a risk factor for vein occlusion and cardiological risk factors, he considers him a non-inflammatory branch vein occlusion and injects Avastin. Patient improves, then deteriorates again. Diagnosis is only suspected when anterior or posterior fulminant reaction occurs and overlaps with the original disease, the vein occlusion. Yet the patient is very late to be starting his treatment for vasculitis. So he goes even blind from further vascular occlusion or optic atrophy. Did the doctor miss something? Again, yes. So he didn't check for vasculitic cause for vein occlusion. It's a recognizable cause for vein occlusion that you have vasculitis, especially in young age. And second, he didn't check the vitreous haze overlying this area of the retina that is occluded. And this patient actually, in particular, had a +2 vitreous inflammation. And when he was asked about oral and gentle ulcers, yes, he said yes. So he is a Behçet patient eventually, according to the criteria of classification. The third case, here comes the third and last case. She's a female, 35-year-old female, presents with bilateral mild anterior reaction. Then the non-suspecting physician, he didn't think about Behçet at first, as she was a female. The fundus looked normal, so he treated her with topical and low-dose oral steroids without identifying the cause. Diagnosis suspected when the inflammation didn't subside easily. She was referred to a female immunologist. The female immunologist, diagnosed her, and finally, the patient gets her treatment, yet a bit late. In this last case, did the doctor again miss something? Yes, and no. First thing, he doubted the diagnosis of Behçet simply because she was a female, although in our studies, it's up to 10% of the patients are females. And in other areas of the world, even the percentage may be even 3 or 5%. He relied on fundus examination, yet sometimes peripheral vasculitis cannot be perceived by your own eyes. You have to do a fluorescein angiography if you're suspecting that your patient might have a disease connected to a renal vasculitis. Peripheral vasculitis can be detected better by fluorescein angiography. And you have to specify for the investigation consultant the area of the retina you want to highlight. So female patients are the third thing. Maybe it's not the physician's direct, a direct mistake, but female patients are often embarrassed to talk about some systemic details in front of male doctors. So it's better to refer her to a female immunologist. These are one of the common steroid-sparing agents. We prefer cyclosporin and azathioprine in our armamentarium. And the recent biological game changers, the infliximab and adalimumab, yet they have also their failures, which we have discovered recently. So thanks to our team, the Uveitis Clinic, and in collaboration with the Immunology and Rheumatology Department. Without them, we've been lost. So don't lose hope when confronted with this vicious enemy. And thank you, everyone.